Good evening and welcome to Series 3 of PRISM Talks, an initiative by our own organization, Chennai Liver Foundation. For those who are joining us for the first time, PRISM stands for Progress in Research, Innovation, Science and Medicine. And that's exactly what we're here to celebrate. The previous two sessions was on how to write a grant and something on research we did. So what we aim to bring in this series, and probably every month we'll be conducting one webinar like this, is to bring all the thought leaders, change makers, and all the stalwarts in various fields to spark conversations that challenge status quo, share breakthrough ideas, and highlight real-world impact in liver health and, of course, in other areas of science. In this series, we focus on a topic of immense public health, pregnancy and viral hepatitis. Not many would know how to manage viral hepatitis in pregnancy. So from diagnosis to treatment, to stigma, to safety, and of course, we are also going to discuss the long-term effects of both the mother and the child. So our aim is to build awareness and advocate for better care and, of course, inspire others so that they can take up various challenges and, of course, also help in collaboration and do research in a collaborative way. For those who've joined us for the last 2 months and those who've joined us this time, we thank you for being this part of the journey. Thank you once again on this journey of knowledge, inspiration, and progress. And to deliver this very important talk, we have Dr. Murugan, who is a very, very good friend of ours and who we've known for very many years now. He is a senior consultant in hepatology and liver transplant at the Apollo Hospitals, Chennai. His research interests include non-invasive fibrosis assessment of the liver, ACLF for acute and chronic liver failure, autoimmune liver diseases, and metabolic associated liver diseases. He's got over 20 publications to his credit. He's been awarded the Best Doctor Award from the Tamil Nadu Medical MGR University. He's one of the senior hepatologists in the country with over 25 years of experience. He's helped set up hepatology services at Apollo Chennai. He has an experience of over 1,200 liver transplants over the last 16 years. An active researcher, faculty at national meetings, and teacher and guide for many students. So once again, welcome all of you all, and I welcome Dr. Murugan. And Murugan, the stage is yours.
Thank you, Vivek. I'm really happy and excited to be part of the PRISM. As you said, this is a very important topic, not only in terms of clinical implications, but also in terms of public health. And it's a kind of a gray area in medicine, including hepatology, where not many people are fully experienced in treating these disorders, partly because it's not that common. And it's a shared expertise between physician, hepatology, obstetrician. So it's more a practical outlook on viral hepatitis in pregnancy. Obviously, there may be areas which I haven't covered, which you may have doubts about. So hopefully we'll have some Q&A to address that. So broadly, we'll be talking on clinical implications in pregnancy, mainly focusing on hepatitis B and C, steps to prevent mother-to-child transmission, which is a major public health concern, some protocols for screening and management, and to leverage antenatal platforms to eliminate and stick to the hepatitis elimination goals of WHO and WHA. I'll focus more on the clinical side of things, being a clinician. And obviously, we are all interested in public health, but I'm not a public health expert. So from a clinician's viewpoint, I'll be highlighting some public health issues. There are many in the audience who may have better public health knowledge, and we can share our experiences and thoughts. So WHO, I mean, this sets the ball rolling. WHO set the goal of eliminating hepatitis as a threat to public health by 2030. A major chink in the armor is the mother-to-child transmission, particularly for hepatitis B. And it is a key step to stop this, to eliminate viral hepatitis in many parts of the world, where this is a key mode of transmission. So as many of you who follow viral hepatitis will know, that the WHO and the WHA, the World Health Assembly, has endorsed a strategy of elimination of viral hepatitis as a public health threat by 2030. And the target set was that you reduce new infection rate by 90% and mortality by 65% in 2030 based on 2015 data. So a 15-year window. We are 2/3 beyond that. So let's see what happens. So some general points about viral hepatitis. So obviously viral hepatitis has many aspects. You have hepatitis A, B, C, D also, and E. And they can all occur during pregnancy, and they all have significant health implications for the mother and child. But today's talk is more on the chronic hepatitis B and C, but I'll just briefly mention about the acute viral hepatitis so that you have an idea. Acute viral hepatitis are mainly food and waterborne illnesses, chiefly hepatitis A and E, and they can occur to anyone, including pregnant women. Unfortunately, if they get sick during pregnancy, it increases the risk of adverse pregnancy outcomes, fetal liver injury, and may also cause mother-to-child transmission of both hepatitis A and E. Hepatitis E is a particular threat in pregnancy, which is a unique combination. And it is more common in our country and neighboring countries because we are in an endemic area. And outbreaks do happen. And if a pregnant woman happens to be infected, they can become really sick. So not only it occurs more commonly in pregnant women, it can also be more severe. As you can see, hepatitis C occurs in 17.3% as compared to 2.1% in outbreak situations. Acute liver failure can develop in a significant proportion of hepatitis C, especially in second and third trimester. And the incidence are definitely higher in pregnant women than in non-pregnant women and men. This was a nice paper from Kashmir in 2006. Overall, in HIV infection, a 30% mortality can occur, which is very high. Luckily, we are seeing less of these and we don't see outbreaks as much. It's isolated cases and the mortality rates are much lower. The two genotypes are responsible, which are both common in India. And HIV can cause a lot of immunological changes, inflammatory pathways activated, like any viral infection can do, and seems to be particularly more severe in pregnant women, and a whole host of complications leading to both maternal and fetal death can occur. Acute hepatitis B is less common in pregnancy because you need exposure during pregnancy to contaminated needles or body fluids. But if it does occur, spontaneous clearance may be less because of the altered immunogenicity in pregnancy. You can diagnose it by standard testing, HPSAG, anti-HBC IgM, and either a NAT test or DNA to look at nucleic acid material. Antivirals are generally not required, and there are some safety concerns in early stages of pregnancy. But if the HBV does not clear, you can consider antiviral in the last trimester, not only to help the mother to get better, but also to prevent transfer to the child. So acute hepatitis B infection can cause increased maternal and fetal complications and mortality. So we'll come to the main areas of discussion. First will be chronic hepatitis B in pregnancy, and later I'll talk about chronic hepatitis C. So chronic hepatitis B does have clinical implications in pregnancy. It does have a small impact on pregnancy outcomes and fetus, though it is not too bad. But if a patient has cirrhosis with hepatitis B and gets pregnant, they can get complications. I've had a few girls who went through pregnancy so far without any major implications, but it's always a risk to have cirrhosis and have pregnancy with hepatitis B. There is always a risk of viral reactivation due to pregnancy. And of course, the main concern in public health is mother-to-child transmission from in patients who have hepatitis B. So, like I mentioned, significant complications are rare, and that is good. Some of the complications you can expect in chronic hepatitis B is placenta abruption, preterm birth, gestational hypertension, fetal growth restriction, and so on. Like I said, they are not common. HBV infection, however, seems to increase the risk of gestational diabetes in pregnant women by a small percentage of 16%. These were all from a large Chinese study and a meta-analysis which have kind of highlighted these points. And this large case control study in China showed that if there is a high maternal viral load in the second trimester, there may be an increased risk of preterm birth and some fetal abnormalities as well. In HBV cirrhosis and pregnancy, maternal mortality can occur mainly due to varicose hemorrhage because many of them have portal hypertension. Because of the high volume and hormonal changes in pregnancy, the portal hypertension can increase in severity, leading to varices and bleeding, and that can have a mortality in the mother. There is also a risk of what we call hepatitis B flare. What this means is a virus which is previously very low or inactive or not present, the DNA, suddenly can increase. So the DNA shows the activity of the virus. So if the hepatitis B with DNA is low, then the patient is inactive. So if it can go up during pregnancy, but it is uncommon. So not only does the hepatitis B viral DNA goes up, it also causes an inflammatory response in the liver. And you get what is then called as a ALT flare. This is the liver enzyme called ALT, which goes up more than 2 times. And this can occur in around 14% of pregnancy. If you can get a severe ALT flare, which is more than 5 or 10 times, but this occurs much less frequently in about 5% of pregnancy. And overall, 12% of patients who have these flares may get significant liver disease like jaundice and hepatic decompensation. There is also a condition called acute on chronic liver failure, where patients who already have cirrhosis are becoming pregnant. The virus suddenly activates, and then the patients can go into liver failure. Thankfully, all these are not common. They can be controlled. So in summary, mild ALT flares during and even shortly after delivery are not uncommon, whereas hepatic decompensation, liver failure are rare. And this was again from a series of studies which was then mentioned in the APASL guidelines of 2022. So when you talk about implications of chronic hepatitis B in pregnancy, there are different clinical scenarios that one can counter. First is somebody who has chronic hepatitis B, who's already on long-term antiviral therapy, and then they become pregnant. So when this happens, what should we worry about or what should we look out for? One is they're already on nucleic acid or nucleotide or nucleoside. NA means it's an antiviral drug called nucleotide analog. So this is the standard treatment for hepatitis B. So they're already on this drug. Whether this would increase the risk of fetal abnormalities if it is continued throughout the pregnancy. And then if you're worried about fetal abnormalities and you discontinue, would it jeopardize the liver condition of the mother? Will they become severely ill and adversely affect the fetus? So these are the considerations we have as a clinician. So as far as fetal abnormalities are concerned, the commonly used drug entecavir is not recommended in pregnancy because it is considered a category C drug, which means there is a risk of fetal abnormality in animal studies, not fully confirmed in humans. Telbutamine is a drug that can be used along with lamivudine, but we don't use it anymore because of high degree of resistance. And the third drug that can be used is tenofovir. And this is a class B drug where there is no risk in animal studies, but unknown in humans, not been tested enough. There is a newer version of tenofovir called tenofovir alafenamide, which has a better side effect profile. But the use of TAF in pregnancy is limited, so we don't know whether it's safe. If there's no other option, we can try it. But the only caveat is TAF is not recommended during breastfeeding as of now based on studies. So putting all this together, it is best to use tenofovir if at all one has to use an antiviral in pregnancy, preferably in the 3rd trimester where possible. So what happens then? Okay, you're worried about some fetal abnormality because you're going to continue antiviral throughout the pregnancy. Will there be liver deterioration? Yes, there can be. It's generally known that in a non-pregnant normal adult, normal meaning non-pregnant adult, if you stop nucleic acid, NA therapy, nucleotide therapy, antiviral. About half of them can have a relapse, usually within 1 year. And if you wait 2 or 3 years, many more can have a relapse. So when you stop antiviral therapy for some reason, there is a risk of a relapse. So what if this happens during pregnancy? That is a concern for us in today's talk. If you do stop antiviral, ALT flash can occur in a significant proportion of patients. This has been shown in observational studies. In some situations, acute exacerbation with liver failure requiring urgent liver transplant has been reported. So it is with some concern that you have to consider stopping antiviral therapy in somebody who's already taking it for a liver disease prior to pregnancy. So in that situation, it is better that NA has continued throughout the pregnancy, including early postpartum, to avoid this uncontrolled HBV reactivation. If you decide to do that based on your clinical judgment, then best is to use the safest drug that is available, which is tenofovir. This is especially stronger if the patient already has a lot of liver damage, advanced fibrosis, or early stages of cirrhosis, because these are the patients who can go into liver failure and may die or may even end up with a liver transplant. So based on, again, studies, these kind of flares, mortality, fetal death occur in 15%, mortality in about 1.8%, and fetal death in about 5%. If you stop treatment in patients who need the treatment or who have fibrosis. So this has to be really looked at carefully before just stopping, chopping and changing, and always better to consult someone with experience or expertise. The second scenario is somebody who is not who has chronic hepatitis B, but they're not on treatment before they become pregnant. Either they have not been screened adequately or they don't need treatment as per the treating doctor, and then they become pregnant. What do we do? Spontaneously, the hepatitis DNA can increase, and they are called hepatitis DNA flares, and they increase by 2 log IU per ml. And along with that, the ALT flare, that means the inflammation of the liver, can also happen, which is defined by 5 or 10 times increase in ALT. This can happen in 9 and 6% during pregnancy, and even after pregnancy within 3 months, 4 and 10%. So a small percentage of pregnant women who don't need treatment prior to becoming pregnant, during pregnancy can have an activation of the virus. Most of these flares are observed in the second trimester or earlier, but some of them can occur in the third trimester. So what do you do for a woman who is HPV infected, is not on antiviral drugs because she didn't need it, then she becomes pregnant? Should we treat them? We don't know. But definitely close monitoring of DNA and ALT profiles during pregnancy and in the postpartum period is recommended, and it has to be very close monitoring every month or 2 months or 3 months. Usually DNA every 3 months and LFT every month is what I recommend. And there is a case for starting treatment in selected group of patients, especially if the DNA is slightly higher. So we'll come to that in later slides. The monitoring for these patients should be during the pregnancy and for 6 months post-delivery, because post-delivery reactivation has also been noted. The pregnant woman goes through a series of immunological changes, which make it inconsistent in how the hepatitis B virus responds to pregnancy changes. Sometimes they activate during the pregnancy, sometimes post-delivery. This is also seen typically in autoimmune hepatitis, where the flare of autoimmune hepatitis occurs after delivery and not during the pregnancy due to the T lymphocyte changes that happen. So this immune imbalance causes changes in the patient's normal status. If any ALT elevation or DNA elevation is noticed anytime during pregnancy or after, immediately antiviral therapy should be implemented to prevent further deterioration in the mother. Again, especially if the mother has fibrosis and so on. So the APASL guidelines of 2022 is a beautiful guideline which has gone into the depths of hepatitis B and C in pregnancy. This is mainly hepatitis B, particularly in an area where this is very common, and many of these studies came from China, but it's a collaborative Asia-Pacific effort to do these guidelines, which includes India and other countries. So they have mentioned that women already on nucleic acid treatment before pregnancy, and especially if they have advanced cirrhosis, you continue the antiviral treatment throughout the pregnancy. Women already on treatment, but with less amount of fibrosis or no fibrosis, whether we should continue nucleic acid, NA therapy, should be considered. It is an open kind of suggestion, not fully clear whether this is right or wrong. So it left to clinical decision making of the person treating the mother. If you're planning to use antiviral during pregnancy, switch from a class C to a class B medication. And the recommended medication is tenofovir as of now. For chronic hepatitis B infected females not on antiviral treatment, regular monitoring is required during the pregnancy and for 6 months after. Pregnant women with chronic HBV and established cirrhosis should undergo a surveillance endoscopy prior to the pregnancy to make sure that they don't have varices and they are safe. I've counseled a lot of women in this situation, and many went on to become pregnant. It's always tricky because if they get sick, they'll get really sick and they may lose their lives or lose the baby or both. So we always caution them, but my experience, at least 2 out of 3 will go ahead with the pregnancy because there is so much of compulsion in their minds. Maybe 1 out of 3, especially if they have advanced stages of cirrhosis or have had complications, may choose not to go ahead. But it is a tricky situation. If a pregnant mother with cirrhosis happens to go through the pregnancy, then regular screening, monitoring is required, especially variceal screening and therapy, because many of them die from variceal bleed in the 3rd trimester. So try to do the damage limitation and treatment before the 3rd trimester in the 1st and 2nd trimesters. So we come to probably the most important aspect of chronic hepatitis B in pregnancy as far as elimination of virus, public health, etc., is the mother-to-child transmission of hepatitis B. It is a major cause of chronic hepatitis B infection, probably the most important cause of transfer of hepatitis B in certain countries. Without any treatment or prophylaxis, mother-to-child transmission will occur in almost 90%, but this almost never happens now. Now we use hepatitis B immunoglobulin for infants and hepatitis B vaccine for infants. And with this combination, the rates of transfer are much lower, probably closer to the 0.1%, not the 4 to 10%, with this combination of HB and hepatitis B vaccine. We also combine it with antiviral for the mother when the viral load is very high and there is a high risk of maternal to child transfer. Again, I will touch upon it in the next couple of slides. When there is a transfer of virus from mother to child, again, which should be less than 0.1% if you follow the good immunoprophylaxis. Almost all of this occurs during the intrapartum period, which is during labor. Maternal blood can cause a placenta during labor. In the first stage of labor, there are contractions where maternal to fetal microtransfusions or transplacental leakage can happen. And then there's the entry of the virus into the infants. During the 2nd stage of labor, there is a direct contact of the infant with HPV containing body fluids of the mother, and maybe through aberrations in skin and mucosa. So all infants who are born to HBsAg mothers, regardless of the activity of the mother, undergo some exposure, which is why universal immunoprophylaxis is absolute must. So since all this happens during labor, why not just do cesarean section for all HPV mothers? Is that something that we should consider? Well, yes and no. The risk of HPV infection in cesarean births is lower than vaginal delivery, but this was only in mothers who don't have good antiviral or immunoprophylaxis. If you're able to do good antiviral prophylaxis for high DNA in the mother and immunoprophylaxis for the child, there is no difference between the cesarean and normal delivery. So it is not considered just for this reason. If there is another reason to do cesarean, yes, you may do so. But it is not recommended to do cesarean just to prevent viral transfer, because it can be prevented adequately with other measures. That's what this means. So what are the risk factors we already touched upon for mother to child transmission of hepatitis B? The single biggest risk factor is the DNA. The higher the DNA, the more the risk of transfer. Various studies have been done both from Asia, particularly from China and from the West. And they've shown, using both Chinese reagents and well-tested US and European agents like Abbott and Roche, that somewhere between 10 to the power of 5 to 10 to the power of 7 DNA is the risk for maternal to child transfer. So WHO did a meta-analysis in 2020 to look at this, along with other data, to look at this particular aspect. And they found that the maximum risk occurred is assuming you have given good immunoprophylaxis, timely vaccine, and HBIG. If the DNA was below 200,000 international units, that is 5.3 log international units, then no breakthrough infection will occur. So this seems to be a good number, that if it is below that, you don't have to worry about maternal to child transfer, provided immunoprophylaxis is adequate. Above that number, the immunoprophylaxis may not work and a few percentage of children may get it. Therefore, WHO has recommended, and it is universally accepted, that a cutoff of 200,000 is a threshold for risk of MTCT of the immunoprophylaxis. So if a mother has a level more than that, then antiviral drugs are used in the third trimester to reduce the viral load either to very low or zero, or definitely below the 200,000 threshold. This is a rather high level, and talking to mothers and asking them to accept this is very hard because they are really, really anxious. And there's also the question of whether they'll be safe to have that level without any ALT flare or other problems in the third trimester. So these are areas of discussion where there is no answer, and sometimes we end up treating them at a bit lower level. So some more points about mother to child transfer. It may be the leading mode of transfer of virus in endemic populations. As you all know, there are two main ways hepatitis B gets transferred. One is a mother to child, and other is contaminated blood or body fluids through needles and so on. So this is an important, or maybe the most common mode of transmission of virus in certain populations. The infected children then become a reservoir of infection, and they then horizontally transfer the virus between other children. The mother who may get it from her mother or who already has the virus and not tested or not adequately treated will continue to transfer to other infants, and the cycle carries on. So preventing a mother to child transfer is perhaps a very, very effective and maybe the most effective way to interrupt this cycle and thus reduce the prevalence and achieve our goal of elimination of hepatitis B. I didn't put this statistic, but it's important to remember that when you get hepatitis B as an adult, only 5, maybe 6, 7% will become chronic carriers. The remaining adults are able to kill the virus and remove it themselves. If you get hepatitis B as children, especially below 5, the reverse happens. Only 5% are able to clear the virus, and 90 to 95% become chronic HPV infections. So there is not only the risk of transmission among communities because from children to children and to successive generations, but also liver disease, liver cancer, liver failure, liver transplant in children in their teens. So it is a huge problem unless we cut it in the bud. So so without intervention, MTCT occurs, as we shared this statistic before, 70 to 90% in mother who's positive in E positive and 10 to 30% if they're E negative. So by birth vaccination, you can reduce it. Interestingly, just a single vaccination at the time of birth itself cuts the risk of infection by 70 to 90. But obviously, this is not enough. You have to give all the 3 or 4 doses to complete the vaccination cycle, and then you can reduce the risk of infection to less than 5%, probably with immunoglobulin, even less than 1%. So it is mandatory that all infants who have HBsAg positive mothers should receive a dose of hepatitis vaccine, preferably within 24 hours, and most importantly, complete the vaccination series. Thankfully, in India, the guidelines have kicked in and all children get the same vaccination schedule, even if they have positive mothers. Only the addition will be the HB given to these infants after birth. A systemic Cochrane review showed that a combination of hepatitis B vaccine with HB is more efficient in reducing mother-to-child transmission than either vaccine or HB alone. So this is the recommendation at present. So just to sum up the recommendations, all newborns should receive the first dose of vaccine as soon as possible, preferably within 24 hours. This should be followed by 3 vaccinations to complete the series. HB prophylaxis may be of additional benefit if a mother is highly active, but it is recommended for all HBsAg positive mothers. The HB is given within 12 hours of birth, and the dose is 10 microgram or 0.5 ml. Pregnant females with a high viral load of greater than 200,000 should receive antiviral prophylaxis to prevent mother-to-child transmission in the 3rd trimester. In resource-poor countries, this was a study from Cambodia, where they showed that if DNA testing is not widely available or not widely used, a cheaper HBe-AG testing and ALT can be used as a surrogate to see which mothers are highly transmissible, and in them, tenofovir prophylaxis can be started along with the immunoprophylaxis for the infant. So all these strategies really help to reduce transfer to almost zero. Tenofovir is a recommended drug for antiviral prophylaxis. It is initiated at 24-28 weeks of gestation. Probably 24 weeks is a good time. Those who take the antiviral can stop it after delivery, but it is recommended to take it for up to 12 weeks. It is okay for breastfeeding and does not interfere with breastfeeding. If a pregnant woman has ALT flares, then they should continue long-term antiviral therapy even after delivery, and obviously followed by a specialist to decide the timing of treatment and so on. And generally, it is recommended that all HBsAg positive mothers are followed for 6 months postpartum, which many times we fail to do because of the changes that can occur even after the delivery. So the areas of concern or future research or discussion is some of 1 or 2 points I've already touched upon. Whether to continue antiviral in females already on antiviral treatment before pregnancy, but they don't have very advanced fibrosis. The answer as of now is yes, you do continue in almost all patients, even in the 1st trimester, using a safer drug like tenofovir. The final data, we don't have to conclusively decide. Whether to start antiviral in pregnant women who before getting pregnant did not need anti-HBV therapy. The reason for this doubt is, what if the hepatitis B starts increasing after pregnancy? I mentioned about DNA and ALT flare, and then we'll end up with a mother who's very sick in the 2nd or 3rd trimester. So why not treat everyone? Especially if the treatment viral DNA level is in the treatment range for normal adults who are not pregnant. So generally, we have a cutoff of 2,000 where we consider antiviral. So should we not treat all these women who are above 2,000? Again, we don't have the answer, but many times we end up treating, especially 4 log, 20,000. If the DNA is more than 200,000, that is a high risk for maternal to child transfer. So in those patients, definitely we need treatment. But if they have less fibrosis and less DNA than 200,000, should they be treated? So all these are areas where we don't know a clear answer. TAF, tenofovir alafenamide, is now more widely used in most adults who are not pregnant. So should that also be used in pregnancy because of less side effects? There is some small data on its safety, but we need a couple of large studies to convince that yes, TAF can be safely used. And then when to stop antiviral after delivery in women, depending on the different scenarios they come into pregnancy with. Again, we don't have clear data. We just follow maybe logic, close follow-up, discussion, experience, and then take a decision, but we don't have clear data. So some final thoughts on chronic hepatitis B in pregnancy in terms of public health. As I mentioned, hepatitis B is a major cause of morbidity and mortality, particularly in the Asia-Pacific region. The burden of hepatitis B is disproportionately high in low and middle income countries. And in these countries, most of the hepatitis B is acquired soon after birth or during early childhood. As we discussed, we want to eliminate viral hepatitis. So one of the key determinants of that is HbA1c in children under 5 years should be less than 0.1% by 2030. And this can be done by universal vaccination, particular care for children born from hepatitis B mothers, including using immunoglobulin and a very early vaccination initiation in these children, and to make sure they complete the target 3 or 4 vaccinations. Other global targets will be 90% of coverage of timely hepatitis B birth dose vaccination. So this is at the time of birth within 24 hours. And then 90% coverage of the 3 vaccination schedules after the first dose vaccination. So there are 2 regimes suggested by WHO. One is you give the birth vaccination, and then if you're using it as a combined vaccine with TPT, then you give 3 more after the first dose. So using hepatitis B separately, give 2 more doses. As far as I know, in India, we are using combined vaccine. I've seen some schedules which give 1 + 3, some give 1 + 2. So somebody can correct me on that, but this is what I understand. So ideally, if it's combined, we need totally 4 vaccines. If it is separate Hep B, we need 3 vaccines. So this is more of the same, so I'll skip this. So 3 important points in the final recommendations. This is from APASL. All pregnant women should be screened for HbA1c. Pre- and post-test counseling should be done, and linkage to further care is appropriate, especially if they have cirrhosis. And scaling up timely birth dose of hepatitis B vaccination may be probably the most cost-effective option for preventing mother-to-child transfer. So I'll quickly run through hepatitis C. Hepatitis C in pregnancy is not necessarily a public health concern because the rate of complications and the rate of maternal to child transfer are much lower compared to hepatitis B. Again, WHO recommends a 90% reduction in new HCV infections and a 65% reduction in HCV deaths by 2030. Pregnant women have a prevalence of hepatitis C similar to general population, which is 1 to 2%. In some parts of the world, particularly North Africa, Egypt, the prevalence is much higher. If you have detectable antibodies, HCV RNA is used to confirm the presence of the virus. Sometimes you can clear the virus and just have the antibody, and this will be occurring in 75% of women. If there is a co-infection or drug addiction, the risks to the mother and the prevalences are much higher. In general, pregnancy does not affect the clinical course of HCV. And in large observational studies, there's been no major fetal obstetric complications. Some have shown that some birth-related abnormalities like low birth weight, neonatal jaundice, admission to neonatal intensive care can occur. They're not well validated. It seems to happen more in women who have co-infection or IV drug users, or other factors may be at play. One thing that has been noted is the increased incidence of cholestasis of pregnancy, the intrahepatic cholestasis of pregnancy, which occurs in the third trimester. Seems to be more common in HCV. And if there are cirrhosis, then the complications of cirrhosis, varicose hemorrhage can occur in these people too. So the US Task Force, CDC, ACOG all recommend universal HCV screening of all mothers in the antenatal, prenatal care setting. The test that is done is HCV antibody test. If it is positive, a HCV RNA should be done to confirm the presence of virus. Some specific guidelines have been given for obstetricians in those who have HCV to prevent transfer into the fetus, to avoid chorionic villus sampling, avoidance of internal fetal monitoring during labor, avoiding episiotomy, and so on. The mode of delivery can be normal or cesarean as appropriate. There is no increased risk in either of them. I mean, there's no difference between the risk in either of them. What about antiviral treatment of hepatitis C? The preferred treatment for hepatitis C is called direct-acting antiviral. It's a combination of sofosbuvir with either levetiracetam or valproatin, which is what we use now. DAAs are, as of now, not recommended to be used. A drug which we have used earlier called ribavirin is anyway contraindicated in pregnancy due to its known teratogenicity. Can DAA be given in pregnancy? Small case series have come in the last 10 years, 6-7 years, which showed that it can be given safely. This was levetiracetam-sofosbuvir combination with a 100% success rate in small groups of patients with no safety concerns. But since there's no conclusive data, it is as of now not recommended during pregnancy. But the AASLD guidelines say that DAA treatment can be considered during pregnancy on an individual basis. For example, somebody has a lot of fibrosis or early cirrhosis, and they have found out they're pregnant and having virus. Yeah, you can consider. Pregnancy impact on HCV infection does not negatively affect chronic HCV infection. Very interesting thing happened in HCV. The ALT level may increase in various ways in first and third trimester, may also increase after delivery. But interestingly, HCV RNA will increase during the pregnancy, but may decrease postpartum. In fact, HCV infected persons have a higher incidence of even viral clearance after the delivery. One worry, though, is HCV infected persons have a higher incidence of intrahepatic cholestasis, which has been showed in meta-analysis. This can have an adverse maternal and fetal outcome. But should we treat all of them with DAA to prevent this? We don't have data yet. And the incidence is not very high, few percentage. So as of now, we don't recommend universal or standard treatment. Pregnant person with cirrhosis obviously will have poorer outcomes, so they should be careful to be avoided if possible. If you have hepatitis C, a transfer rate is between 5 to 10%, and the infant can progress to chronic infection in 3 to 4% of the time. DAAs, again, there is no significant toxicity in animal. There are some human studies that show efficacy, but should we use it on all patients with HCV and active virus? We still don't have the data. This was a paper published last year in Lancet, which looked at overall the HCV burden in pregnancy and DAA treatment. It was a systematic review and meta-analysis. They found that the transfer rate between mother to child was around 9%, which is fairly significant. Pregnant women may have more maternal complications. Neonates may have the odds of being small for gestational age. The last paragraph is very interesting. The pooled rate of SVR, which is complete viral clearance, was 98.4% in 74 women treated with this drug, with no serious adverse events. So it's very hopeful that we could reach a stage very soon where DAA can be offered to all pregnant women and reduce its small 5 to 10% risk of transfer to the child and also both maternal and fetal problems during the pregnancy. So it can play a role to minimize that. Postpartum HCV is not, breastfeeding not a risk in HCV. And this is what I mentioned, HCV levels can fluctuate during pregnancy. And sometimes spontaneous clearance can occur in the postpartum period, even up to 25%. So that is good news. And all women should have the RNA reevaluated after delivery. So this is just a summary of what I just told you. All pregnant women in the prenatal care should have HCV infection tested along with hepatitis B. For women of reproductive age with known HCV, antiviral therapy is recommended before considering pregnancy. So if at all you want to treat, you treat them before they become pregnant. So if somebody comes to me as a young woman for counseling, this is what I advise them. The same for hepatitis B, control the virus before becoming pregnant. This is a summary of what I just went through, so I won't go through it. So to conclude, I'll focus on the WHO elimination goals. Acute viral hepatitis, especially hepatitis E, can adversely affect pregnancy outcomes, particularly in endemic countries like India, and precautions to be taken as adequately. Basically, to be careful in outbreaks and to avoid the contamination food and water when you're pregnant. Screening of all pregnant mothers in the antenatal period is really mandatory for hepatitis B, C, and HIV. Chronic hepatitis B, protect the mother with all the caveats that we discussed. Still, there are gaps in the knowledge and in the data, but by and large, make sure the mother is protected. Key to prevent mother-to-child transmission, to break this chain of hepatitis B transfer and to achieve elimination goals. Prevent mother-to-child transfer in high viral load, particularly by giving antiviral, along with standard immunoprophylaxis for all infants, both immunoglobulin and hepatitis B vaccine. At birth, and this will complete the cycle, to prevent MTCT and break the cycle of viral transfer, use HBIG, use infant vaccination at birth, complete the vaccination cycle, and ideally check antibodies at 12 months. This is actually a recommendation from APASL, but I don't know how if in real world it is actually followed. Even adults don't follow it, but it's always important to check for antibodies in a high-risk child whose parents mother may have hepatitis B. For HCV, the risk of transfer is low. There is no vaccine or immunoglobulin to protect the infant. DAA treatment of all mothers with HCV may be an option. We need more data to confirm that. So thank you. So it's a kind of an overview of important aspects. There may be specific areas where we need some clarity. So I'm happy to take questions.
Lovely. Thank you, Murugan. It was fantastic. It was really crisp, and I think you covered all the aspects. So before we go to the question answer sessions, if I may ask the attendees to type in their questions in the QA box, then I would read them out to Dr. Murugan, and he'll be happy to answer all of them. Also, there will be a link to the survey, which will be shared now in the comments. If you can fill in that survey for us, and of course, we'll be sending out a participation certificate to all who've been in this very important meeting. So to begin with, may I ask you one thing, Murugan? What about, you don't touch about vaccination for mothers?
Okay.
So would you do that?
Yeah, I think we are moving towards universal adult vaccination. US has already recommended that. I think in India, due to cost implications and making it universal, maybe we are not there yet. But yeah, ideally, everyone should be vaccinated for hepatitis B. So we start with children, maybe using, antenatal or mother of childbearing age. That will be the right terminology. Yeah, it's a good strategy, I think. I don't know if it is recommended as a guideline in anywhere, but I've not come across that. But I think it's a good strategy. So all women of childbearing age should be vaccinated.
Yeah. But of course, I'm sure you're aware that in India, we've got some shortage of vaccines also these
Yeah,
days.
I know. But as you know, US CDC, ASLD has recommended all adults be screened and vaccinated in
Correct.
the last 2-3 years. So they are going at it really hard.
Okay, so one Vishal Gupta is asking you, of course, he's congratulated on your talk, and he's asking pregnant women with core total positive and HBsAg negative, any intermittent
Okay.
test required?
No, they are basically virus-free, but they have had previous exposure. These individuals can reactivate in a very highly immunosuppressed environment, mainly with cancer chemotherapy. That will particularly be lymphocyte depleting chemotherapy like rituximab. But in pregnancy, there is no risk of reactivation, so they don't need any additional treatment for hepatitis B. The child, as usual, needs hepatitis B vaccination. So all children need it anyway, so they'll be getting it. HBIG is not required for the child.
Right. Because the other question is, why do you think hepatitis E is more virulent than hepatitis A? Because we only speak of Hep B and pregnancy, right? Most of the time.
Yeah, it's to do with the immune response to hepatitis E. So I think it has some proteins which trigger this, and it seems to be more vigorous and more aggressive during pregnancy. I think pregnancy changes a lot of hormonal, there's a lot of hormonal changes which also changes the immune environment of the individual. So it seems to have a more aggressive response to the E virus proteins, particularly the type 1 and 2. So they seem to react more aggressively to that compared to other acute viral hepatitis. So this seems to be the reason. There's nothing much we can do about it except prevent exposure. There are treatment options, particularly ribavirin, but it's contraindicated. Another interesting treatment option is sofosbuvir, which has been studied in non-pregnant women with some success in controlling virus. So when somebody has a very fulminant hepatitis with E, it can be used. It is actually used more for viral persistence, which happens after organ transplant. But even in a fulminant hepatitis, it can be used. The other interesting area, again, which is a kind of a broad area, is HEV vaccination. Already there is a Chinese vaccine which is being used in China for many years. Their results are good. They've also used it in, like you mentioned, women of childbearing age, especially during outbreaks to prevent them from getting hepatitis C. But still WHO has not recommended that to be adopted across the world. They just want more data. So we may get a HEV vaccine as well soon. So I deviated from your main topic, but I thought I'll cover everything by your main question. But that's HEV.
Of course, I think you touched upon this, but I think if you could just summarize about C-section.
Okay.
What is the real evidence today for whether they should undergo C-section or have a normal delivery?
So hepatitis C, there is no difference. So whether you have C-section or normal delivery, the rate of transfer is low in both, and there's not much difference between the two. In hepatitis B, definitely the act of labor increases the viral exposure of the infant, without a doubt. But if you do good immunoprophylaxis with HBIG and vaccination, and if the viral DNA is controlled in the mother, if it is very high, once you do this, then the rate of transfer is same for both cesarean and normal delivery. So given that, and given that we're going to do it for all infants, there is no need to go for cesarean section, just for the sake of viral transfer. If you're not giving immunoprophylaxis and just going through a delivery, then maybe cesarean section is better, but we are not going to do that anymore. So the question doesn't arise. So today you just give immunoprophylaxis, you give immunoglobulin, you give antiviral therapy to the mother if the DNA is high. And with this, you can get almost less than 0.1 transfer. So it's almost zero in whatever delivery you do. So it doesn't matter. No. So today, no. As of today's, with the prophylaxis that we have, we should not recommend cesarean for Hep B mothers just to prevent viral transfer.
So the other thing is, so of course we all live in the cities and corporates where you have access to antivirals and HBIG is not a problem at all. What about those deliveries, which predominantly most of the deliveries happen in rural areas, right?
Yeah, I agree. Vaccination is a must. So I hope the government or whomever is controlling this provides vaccination at least for newborns. I mean, for others, adults, okay, it's less a priority. But this is a must. And whatever I'm reading in the press, the government seems to promise that all newborns will be covered. There is no concern. I don't know how far it's true. Maybe you have some more information. So even if you don't get HBIG, if you can vaccinate the infant at birth, especially within 24 hours, because as I mentioned, just that single dose cuts down the rate of transfer by 70%. And if you complete the vaccination schedule, at even 3 is fine, then you're going to cut the transfer by 95%. HBIG is more important if there is active DNA or HBe positive. If you don't have access to the tests or you don't have access to HBIG, doesn't matter, but vaccination is a must.
And would you say if your mother is HBsAg positive and has got, and they don't have facility for a viral load, okay, would you empirically treat these mothers with tenofovir on the second trimester?
It's a difficult question because you don't know what you're dealing with, and you're still exposing them to possibly a category B drug. So ideally, no. Like I mentioned, there were a couple of studies looking at Cambodia and one other country where they, at that point at time, didn't. This probably was about 6-7 years ago. Didn't have DNA option for all mothers, especially in rural areas. So they did HBe antigen testing. If they were negative, they were not given antiviral. If they were positive, and if ALT was high in the third trimester, they were given antiviral. So they went along that route. But without DNA, it's very hard to know what you're dealing with. I still wouldn't want to give antiviral blindly because if the LFTs are normal, you assume that there is no flare or reactivation and the liver is okay and the virus is also not active. Because if the virus activates, there will be an ALT flare almost always. So you can just go by LFT. And you're going to give vaccination and immunoglobulin to the child so that the transfer is taken care of. So as of now, I wouldn't recommend because it's still a category B drug, which means there is some potential risk.
So the next question is by Dr. Prabha. He asks, if a newborn of hepatitis B positive mother comes after 24 hours, rational to immunize the child with hepatitis B vaccine, until how much time HB can be administered to the child?
The maximum effect, the best effect of HBIC is within 12 hours. It is recommended that you can give it up to 24 hours. Beyond that, the effect may not be very high because, like I mentioned, the exposure happens during labor, or even if it's C-section, some contamination may happen. So the maximum impact of HBIC will be within the first 12 to 24 hours at the most. Beyond that, it may not. Vaccination, you give it at the earliest. Even if you give it after a day or two, doesn't matter. You still give the vaccine. So HBIC maybe up to 24 hours you can give. And again, as I emphasized in my slide, that HBIC is an additional protection. Without HBIC, even up to 90% of transfer can be controlled. HBIC plays more of a role if the maternal DNA is high and they have not been adequately treated. So it is important, but even without that, there will be good protection. So up to 24 hours, I think you can give it. Beyond that, I doubt it will have any effect.
Of course, what is also important is taking care of ourselves, right? The healthcare professionals, aware that the mother is Hep B positive.
Yeah.
You have to make sure there's no splashes and cuts and bruises, and we ourselves should be vaccinated, right?
Yeah, I was going to say that all healthcare people should be vaccinated.
Yeah.
Without a doubt. Again, somehow we should sort out the vaccine problem because it's going to be a big problem. So on the one hand, we're talking about elimination and all these strategies, and your most valuable tool is the vaccine. If that is not there, then nothing we can do.
Correct. Yeah. Good. I think we've had a good 1 hour session. So
Okay.
all the participants, the link of the e-certificate has been sent to you. And of course, there's a feedback form. So once you fill it, we'll be sending out an e-certificate for all of you. And once again, I'd love to thank my good friend, Dr. Murugan.
Thank you.
It was an amazing lecture today, and hope you're all benefited, and hope to see you soon in a month's time. Thanks again, Murugan.
Thank you. Thanks.
Thank you. Thanks very much.